It's a pleasure to be here today in beautiful Riga at the 18th Congress of the Baltic Association of Dermatovenerologists to present this lecture on life-threatening drug eruptions, Stevens-Johnson syndrome, and more. I'm Professor Robert Schwartz, Rutgers University, and I'm grateful that I've been invited. I have no conflicts of interest. I am Vice President of the International Society of Dermatology, International Regional Advisor of the Royal College of Physicians of Edinburgh, Editor-in-Chief of Dermatologic Therapy, and Editorial Advisor, Board Member of American Academy of Dermatology. I'd like to specifically thank my good friend and distinguished professor and president, Andres Rubens, and his wife, for having me here. I wish I could be in person with you. I love Riga. And I'm with you in spirit, I guess. This is, of course, our last meeting in Riga, and it was wonderful, I have to say. Really, I'm very, very grateful to be included in this meeting and in the other meetings as well. So thank you again, Andres, for having me. I'm from Rutgers University, founded in 1766. We're one of 9 surviving colonial colleges. We originated as Queen's College, and so we thank King George III for beginning us in honor of his wife, Queen Charlotte. You've probably heard of some of the other surviving colleges. King's College on the small offshore island of Manhattan, for example, now known as Columbia University. And then you have Harvard and Yale and a few other places that you may have heard of. Life-threatening drug eruptions are exceedingly rare. Drug eruptions from medications are extremely common. But to be severe, and so severe as to threaten one's life, that, thank gosh, is extraordinarily rare. Stevens-Johnson syndrome, toxic epidermal necrolysis, we're talking 1 to 7 per million per year, but a mortality that is significant. Usually the eruptions are not predictable, but sometimes they are. Certain medicines are much more likely than others to cause a problem, and in certain populations we can predict with those certain medicines. So we need to do genetic screening judiciously in selected populations. Here, for example, are some of the problematic medication and some of the populations for whom we're particularly concerned. Allopurinol in Asians, again, we're using that, and that's a commonly used medicine. Sometimes in dermatology we use that. We may want to check for HLA-B 5801, or for dapsone, which we also use, of course, selectively. HLA-B 1301 also. So we can predict with pharmacogenetics, and we need to be aware of that. Now we're going to mainly cover Stevens-Johnson syndrome, toxic epidermal necrolysis, and that occurs in 1 to 8 weeks onset after the medication is first given, as opposed to generalized pustular figurative erythema, a newly described disorder that we'll cover, where we're talking about 1 to 3 weeks, and generalized bullous fixed drug eruption, where we're dealing really in hours. So these eruptions of the skin are not just in the skin. It's not just the skin erupting, but the whole, it's a burn on the inside and the outside. We have an eruption everywhere, akin to, this is Mount Bromo in Indonesia. And of course the skin is erupting here in my patient. You can see diffuse shedding of the skin, big sheets of skin shedding with toxic epidermal necrolysis, the extreme form of this drug eruption. In milder form would be called Stevens-Johnson syndrome. And that's part of, as I'll cover, of the erythema multiforme spectrum. Again, these are pictures that I've published in the lead article that I wrote in the Journal of the American Academy of Dermatology a few years back. And this is an amazing eruption because you have no inflammation, but just dead keratinocytes. That's striking. Now, again, this is part of the erythema multiforme spectrum. We credit Professor von Hebra for describing it as a limited eruption usually caused by herpes simplex virus infections. In 1922, Albert Mason Stevens and Frank Shablis Johnson described in 2 children a new eruptive fever with oral and ocular involvement. We now call that Stevens-Johnson syndrome. And then in 1956, Professor Alan Lyle delineated toxic epidermal necrolysis. As you can see, I've been interested in this category since since the early 1990s. And amazingly, Lyle's 4 patients mostly didn't have this. 2 had generalized bullous fixed drug eruption. 1 had Stevens-Johnson syndrome. And 1 had staphylococcal scalded skin syndrome. So here we are, a patient of mine, typical target lesions. You can see that, well delineated. This guy, every time he got the herpes simplex, it would recur. He did recurrent erythema multiforme. And so you had to suppress the herpes simplex to stop the erythema multiforme, which was more annoying to him than the herpes simplex infection recurrent. This is an older patient of mine with bullous erythema multiforme. We never figured out what the etiology was for her, which is not rare. So erythema multiforme is a frequently recurring mucocutaneous disorder where you have often inflammatory fixed concentric rings of coloration. And it's often self-limited in mild form, 1 to 4 weeks. It may be from infection, it may be from drug. Again, we have the spectrum that I'd like to stress here. Erythema multiforme minor, erythema multiforme major, Stevens-Johnson syndrome, and then, of course, toxic epidermal necrolysis. The terminology is challenging too, as Lyle pointed out in an editorial requiem for toxic epidermal necrolysis. And, of course, the mycoplasmal etiology for severe forms needs to always be considered, as we'll cover. So toxic epidermal necrolysis is characterized by the exfoliation of skin and of mucosa of the oral cavity, of the eye, of the gut, of the kidneys, the lungs. But what's so challenging here is often there is a prodrome, a beginning, non-specific in appearance, with fever, anorexia, pharyngitis, conjunctivitis, and a fine macular papular rash If you're lucky enough to have targetoid lesions, of course, that really points us in the right direction, but it's not always present early. And also, you can create blisters, or you can extend blisters. We have names for that. Notice I use the Ukrainian spelling for Nikolsky. And then, of course, the Ashbo-Hansen sign. One creating a blister, one extending the blister. Okay, and this is, of course, you can see my online book chapter on e-medicine, on toxic epidermal necrolysis, which I updated again this year. And a point that's worth mentioning is you can get Stevens-Johnson syndrome, TEN, after COVID vaccination or from COVID itself, rarely. But we need to know that too. So we have delineations. Below 10% with bullous eruption and really maybe localized target lesions. We talk about bullous erythema multiforme. When there's mucosal involvement, though, we really more clearly delineate it as Stevens-Johnson syndrome, typically widespread, purpuric macules, or these targetoid lesions. When you have 10 to 30%, we talk about the overlap of Stevens-Johnson syndrome, toxic epidermal necrolysis, and then, of course, over 30%, we use the term toxic epidermal necrolysis. We believe it to be a continuum and a challenging, life-threatening, potentially, disorder. So we have mucosal involvement, which is pivotal to make the diagnosis. We worry about the oral lesions, but mainly the ocular and the genital ones too, often. They're seen in virtually all patients with toxic epidermal necrolysis, and the mucosal erosions are often painful to touch. The skin is painful too, by the way. As I mentioned before, the Nikolsky sign is the separation of the papillary dermis from the basal layer upon gentle lateral pressure, whereas the Ashbo-Hansen sign is the lateral extension of a bulla with pressure. And again, here's my lead article in the Journal of the American Academy of Dermatology, from which a number of my clinical pictures were taken in this paper. So toxic epidermal necrolysis may be fatal. It may produce acute renal failure. It may produce adult respiratory distress syndrome, myocarditis, hepatitis, encephalopathy. This is a serious matter. It rarely is a manifestation of severe systemic lupus erythematosus, but that needs to be thought of too. So here we are, again, some of my patients, the massive bulla formation in one of my patients. And here, a clue to a second process. Notice the thrush in the tongue, because the unfortunate individuals that are HIV positive or have HIV disease, AIDS, are much more likely to have this rare skin reaction than others do. 1,000 times more likely, in fact. Anybody can get it, however. Even in the fetus it's been described. And it's no surprise it's seen more commonly in elderly people, because elderly people tend to be on more medicines than younger people. Now, this is one of the common offenders, lamotrigine, Lamictal, it's marketed as in America. It's a high-risk offender with a good percentage of people developing problems with this. A number of these anti-epileptic medicines are problematic. You can see the data here. Most don't have, but again, many have a drug eruption, but not a life-threatening one. So I have a macular papular rash. You stop the medicine, so what? Okay? That's versus when you really have the life-threatening ones, which are very small and, of course, do require hospitalization. So Bioavailability is important too. Often this Lamictal will be given with valproic acid, and with valproic acid given together, you have an increased risk of an adverse reaction that can be severe. So the risk of Stevens-Johnson syndrome, TEN, with antiepileptics is significant. Data has shown that specific medicines, Tegretol, Lamictal, lamotrigine, phenobarb, dilantin, valproic acid, these are much more likely offenders than a number of other medicines. In other words, these are high-risk medicines. We need to know what the high-risk medicines are. And the sulfonamides in that category. And that's more a category we're likely to see in dermatology or use in dermatology. Typically, again, 1 week to 8 weeks after the onset, this will come out. Earlier is more common, actually, between 6 days and 2 weeks. And with re-administration, it can be within hours. That can be deadly. I had a patient, they told her, if you ever take sulfonamide again, it'll kill you. So she didn't take a sulfa drug. She took Bactrim. And of course, that's a combination of a sulfamethoxazole and trimethoprim. And they killed her. Sad, obviously. These days we have computers, and of course the computer should have picked that up. But in any case, Bactrim is a common offender, but also a medicine widely used for good reason. And it may be safer than some of the alternatives, too. But whenever I see Bactrim, I kind of shudder. Because this is the main one I see. Drugs cause 80 to 95% of the toxic epidermal necrolysis. But, again, infection can do it. Mycoplasma in particular. I had one example where, again, we couldn't figure out a medicine at all, but I found that she was a mycoplasma positive serologically, and she had pneumonia. That was obviously the cause in that setting. Dengue can do it too. Reactivation of cytomegalovirus. And again, the vaccinations, including COVID vaccinations, and including COVID itself as an infection, have been linked with Stevens-Johnson syndrome. And you can see there's a number of publications. As editor of a journal, I'm seeing more and more of these submissions. We're publishing them. Other journals are publishing them too. So we need to be aware of that. Cross-reacting drugs, again, sulfonamides cross-react to different types, beta-lactam antibiotics, and then, of course, anti-epileptics too, as we've stressed previously. So what's going on here? This is a very peculiar eruption. There's no inflammation. The cells are just dead. The keratinocytes are necrotic. Well, this is a T-cell mediated disease activating CD8 positive cells as the major mediator of the keratinocyte cell death. And again, certain human leukocyte antigen allotypes are at increased risk, and genetic screening, as I mentioned and stressed, can be important for certain medications with certain drugs. Programmed cell death, apoptosis, which is what's happening here, is triggered by granulysin, but sadly, we cannot do a granulysin test, serum granulysin, for example, in the emergency room. We have no test we can do to determine somebody, let's say, in a possible prodrome period. I've got a fever, I've got a rash, I feel sick, my eyes are watery, I have conjunctivitis. You tell me to go home and take 2 aspirins in the morning. How do you know? We don't know. That's one of the problems. We'd like to have a test. We'd like to be able to test for granulysin B or perforin, things that are elevated. But unfortunately, there are no reliable tests to date. That's just all we can remember again is that, again, if we're using Tegretol, if somebody, my hometown is San Francisco, if I have a Han Chinese person, one of my San Franciscan fellow San Franciscans, I better check for HLA-B1502. That'd be very, very important. So here we are, more of my patients. You can see the blister formation. Here, this is somebody in the ICU, actually. The blisters. And what's the prognosis? Well, we have something people call score 10 as being one of the ways of predicting mortality. To me, it's not so meaningful. The sicker you are, the worse you do. If you're older, you don't do so great. If you have associated cancer, that doesn't help. If you're in renal failure, not good. If you're out of control diabetic, not good. So basically, I think that's very, very important to understand that although we can use these mortality predictors, the context is really, the sicker somebody is, the less well they do. And they have other published approaches: A, B, C, D, 10, age, bicarbonate, cancer, dialysis, and more than 10% of the body. And this ABC10, ABCD10 is as good as score 10 as a mortality predictor. But just recently, this year, there's a possible another predictor projected, checking the red cell distribution width to the hemoglobin ratio as predicting mortality, and that, again, is something worthy of our consideration. But the most important thing is take care of the patient. These people need to be in an ICU, ideally a burn unit. They need lots of support. There's no convincing data. You stop the medicines or only suspect medicines. There's no convincing data that systemic therapy really helps. I myself prefer high-dose steroids, prednisone or prednisolone, early. Others prefer cyclosporin early, IVIG, tumor necrosis factor alpha inhibitors are also used, but there's no great evidence where we're going to make a difference other than with supportive care and protecting the eyes. Because we have to worry about scarring. Not so much in the skin, it's not attractive. Skin scarring, dyspigmentation, alopecia. But the ocular findings can be devastating. From dry eye syndrome, photophobia, to actual corneal scarring and blinding. We worry about periodontal disease too in the oral cavity. For women, particularly, we worry about dyspareunia and vaginal stenosis. So you need OBGYN involved if it's a woman. And of course, the pulmonary effects can be devastating too, with esophageal stenosis and bronchiectasis. So this is a systemic process, an internal and external burn that needs to be intensively followed. So up to 70% of women have acute vulvovaginal disease, and about 28% have chronic vulvovaginal Stevens-Johnson syndrome, toxic epidermal necrolysis. It has to be evaluated. You have to prevent it. That's the game here. Prevent vulvovaginal scarring and stenosis with early initiation of topical steroid high potency applied to the skin, petroleum gauze to prevent contact with adjacent surfaces, eroding mucosal surfaces, mechanical vaginal dilator insertion, and possible menstrual suppression as well. These are very, very, very important approaches for women with SJSTEN. Now, what scares me the most, and this is my patient you can see with a red eye, ocular involvement. This is a blinding disorder in which the severity of the eye and skin involvement do not necessarily have to correlate. So don't be confused. It's 20% of the skin is involved. Don't worry about the eye. Yes, worry about the eye. Ocular acute phase may be part of the prodrome and may reflect skin cell death. Acute ocular findings are common. More than half of patients have them. Early, they're quite variable. Eyelid inflammation and ulceration are often considered prognostic features of this disease. So you get a number of eye findings. Meibomian gland injury, ectropions, punctal occlusion, corneal neovascularization. This can have disabling pain or a threat to the vision, and possible corneal late blindness too. That's another feature that's rather frightening, because the ocular surface changes can be insidious in nature, and again do not correlate or may not correlate with the severity of the acute phase. These findings can take years to manifest. So we have intense inflammation with permanent destruction of mucosal tissue, of the ocular surface and eyelids, and the glandular structures, all too often. And an examination in the emergency room and at bedside may miss that by people not attuned to these ocular features. That often you see a conjunctivitis, but again, you need to look by averting the eyelids, because they may have deep-seated ulcers of the tarsi and the fornices, and they may be hidden without the aversion. And the key is we have an approach that can make a difference. We can transplant fresh or cryopreserved fetal amniotic membrane, and that can save vision. That's really a biologic bandage with anti-inflammatory processes. It's very, very, very important to have that available, to have your ophthalmologist there at bedside. Amniotic membrane transplantation, again, has to be thought of. Sloughing eyelid margins in conjunctiva, again, graft early. There's a very limited window. We're talking, a week to 10 days, where you can really make a difference and prevent scarring, permanent, which is obviously permanent, and its devastating consequences. Now, cost effectiveness. We've stressed the value of genetic testing. The cost effectiveness, for example, of HLA-B 1502 genotyping. It is cost effective in some populations, but not others. For example, a study showed that in Singaporean, Chinese, and Malays, it was cost effective, but in Singaporean Indians, it was not. So you really have to be conversant with these things to prevent. Now, again, it takes a little bit of blood. 5 cc's of blood collected, should be back in a week with a result. And certainly before you use Tegretol or Dilantin, you want to use this testing if you're, for example, in my hometown of San Francisco, where a number of my fellow San Franciscans would fall into the category of Han Chinese and would be, of course, at much increased risk. So we need to keep that in mind. This picture warms my heart because I took this from the top, I believe, of a church in Riga on my last visit, and I love Riga. What a beautiful city. We stayed on the other side of the river. A beautiful hotel where the conference was hosted. Thanks to Andrus. Now, we need to think of a newly described entity too, generalized pustular figurative erythema, which has really come into focus because of the increased use of hydroxychloroquine for COVID. It had been quite popular. And it can produce urticarial or edematous plaques studded with pustules. And there may be targetoid lesions, targetoid erythema multiforme like plaques, widespread figurative erythema with non-follicular pustules, and arcoid and annular patterns too, with occasional blisters or erosions. So one needs to think of this entity. Often it's confused with another entity that I'll cover in a minute. And this can be, of course, challenging to treat as well. So it should be recognized. And you can see again the plaques studded with pustules. And we have, an incubation period, again, of a matter of weeks, not hours or days. And here we are again, under the eruption, the pustules. And again, from a number of Spanish patients with this, we have the histology. And some people confuse this. It's often confused with or misclassified as acute generalized eczematoid pustulosis. That's a generalized eruption where you have these non-follicular pustules within 24 hours, typically from penicillin or sulfa drugs, or as you can see, 10 years ago I wrote with our wonderful colleagues in Bulgaria with oral ketoconazole. But they need to be separated. They're different. Okay, and here we are again thinking of Riga. I wish I was with you. I love Riga. I've been there a few times, and I'm very grateful to be included on this program. So, as I mentioned, Lyle, in describing Lyle's disease, what he called toxic epidermal necrolysis, had 4 patients, one of whom had staphylococcal scalded skin syndrome, not DEN. And this is my patient. You can see this was a patient in the emergency room. And you can see the erosions on the skin. And here we have no necrosis, though, and no inflammation either, but rather acantholysis, because we have blistering eruption or a tender exfoliating erythroderma, which will have a positive or may have a positive Nikolsky sign, a new blister, or extension of an old blister, Ashwell-Hansen sign, and that prodrome of conjunctivitis, pharyngitis, and fever. And of course, this is my paper with Professor Zach Handler covering this topic recently. So adults with underlying disease are at risk, typically renal disease or immunosuppression from a variety of causes. Children under 5 have immature immune systems. We believe reduced renal clearance as well, which may account for its prevalence. But in adults, it actually kills people. 60% mortality rate in adults, whereas under 5% in children. Infants tend to die from electrolyte imbalance, sepsis, or other infections. The adults are pretty sick often to begin with. So this, remember, is a toxin-induced disease. The infection has exotoxins that are released, and this is what causes the process. These toxins target desmoglein 1 in the stratum granulosum, so there's superficial desquamation without mucosal involvement. Okay, and that's a pivotal point. There's a loss of adhesion in the stratum granulosum, giving the blister formation. Little or no dermal infiltrate. There may be some neutrophilic pustules. Unfortunately, we don't really have readily available a test to show the exotoxin A or exotoxin B. Not yet available, at least. And again, comparing staphylococcal scalded skin syndrome with TEN. So blood cultures should be done, of course, and in adults they're often positive, whereas they're negative in children. Nasal swab carriage may reflect non-outbreak strains. The staph may be methicillin sensitive or methicillin resistant, and that's important because it will determine the choice of the antibiotic utilized. Exfoliation or loss of adhesion in the stratum granulosum is, again, the story here, not apoptosis, not programmed cell death. So you don't use steroids. That'd be the wrong thing to do. These people should be, these children should be, or adults should be in a burn or intensive care unit if it's severe. And of course you worry about fluid replacement, wound care. As you can imagine, pain management. And you want to make sure these people, you identify carriers and trace transmission, particularly if there's a child in the neonatal unit. That's very important. Staph scalded skin syndrome is increased in AIDS and HIV patients and in renal failure. As technology allows more premature births, these children are also at increased risk. Nasal carriers are at increased risk, no surprise. IVIG as treatment in children has mixed results. Fresh frozen plasma may have good results. So again, complications may ensue if the diagnosis is not timely. Again, it kills, but not to the rate that it does in adults who all have other serious diseases. Pneumonia is the most frequent complication. And again, antibiotics need to be used, not steroids. So here we are back in memories of Riga together, here with Professor Zerhausen, the Nobelist originally from Latvia. And we had a wonderful time, and I'm so grateful to you, Andres, for hosting that meeting with him, and what a great conference. New topic. Fixed drug eruption. We're all familiar with fixed drug eruptions, but the generalized bullous fixed drug eruption is a rare form. There's really no precise figures. We reviewed this recently. You can see we published in 2020 a paper on fixed drug eruptions, an update emphasizing the potentially lethal generalized bullous fixed drug eruption. And again, there's no good data. It's often misdiagnosed. We have widespread blisters and erosions for at least 10% of the body, but rarely, usually much less than 30%. Hitting multiple anatomic sites. And again, in one study with elderly, there was a mortality of 22%, age-related, over 60. And again, the typical medicines that are associated with this generalized bullous fixed drug eruption are metronidazole, rifampicin, ibuprofen, cotrimoxazole. And you have this, again, a situation where often it's not delineated, but you need to do that, okay? And this is, you can see the blisters. It can be quite widespread. Onset rapid, 1 to 24 hours after ingestion. And that timing is very, very important in our diagnosis. Few, if any, constitutional symptoms, short latent period, and of course there's less mucosal involvement than you get in TEN. It tends to spare the mucosa. You have increased inflammation and hyperpigmentation, as you would expect in a fixed drug eruption. Same site recurrence with exposure to a particular medicine. And again, no target lesions, but it's still often confused with Stevens-Johnson syndrome, TEN, with these blisters. And you can see again another one of my some patient here. So we have, again, vacuolar interface dermatitis, with lymphoeosinophilic infiltrate and pigment incontinence, scattered atypical keratinocyte necrosis, but really more eosinophil infiltration in dermal macrophages than you'd expect in Stevens-Johnson syndrome, toxic epidermal necrolysis. Serum granulysin levels and number of granulysin-expressing cells are much lower than in SJS-TEN, although again, that's a research kind of comment, and I wouldn't hang my hat on that. Now, this is the Baltic Society, and I feel I'd be remiss if I don't pay tribute to my old friend Jonas Lilas. I used to go to Vilnius and Kaunas, and he hosted me, as did, I'm pleased to say, Skydra as well. I'm very grateful for their friendship, and here we are in Trakai, magnificent. Lithuania is a beautiful, beautiful country, and again, we pay honor and tribute to our Lithuanian colleagues, our Baltic colleagues from that great country. In the differential diagnosis is linear IgA bullous dermatosis. This is a drug-induced eruption, typically with vancomycin, but occasionally from dilantin, amoxicillin, lithium, penicillin, etc., where you get tense annular blisters, bulla. Mucosal involvement is not common, typically 2 weeks after the vanco is given, but it may resemble, as you can see in my publication here, it can be quite polymorphic and may resemble toxic epidermal necrolysis. Clearly you want the direct immunofluorescence, which will show the basement membrane zone IgA. And this is again my patient here. Quite striking. Here we are back in Lithuania. Just again, more memories. Skydra, Professor. I'm grateful. We love Lithuania too. And I urge you all to make a side trip to see this great castle fortress as well. And with Professor Golnick here too. We were the visiting professors at that time for that event. Now, pseudoporphyria, and you can see my paper on that, an atypical variant resembling toxic epidermal necrolysis, which I published some years ago. And here's a picture again of my patient. This is a drug and hemodialysis-linked phenomena. The drugs, furosemide particularly, Cipro, localized bulla on sun-exposed areas, often on the dorsum of the hands and fingers. Histologically, it looks like porphyria cutanea tarda, but porphyrin levels in the urine, stool, and blood are normal. And again, rarely you get this generalized variant with rapidly evolving bulla, which become denuded, again then resembling toxic epidermal necrolysis, as I described here in my publication. You can see typically hands, separations. And I will conclude with, again, I'm Polish. I'm proud to be a Polish American, and we Polish stand beside Latvia, Lithuania, and Estonia, our close friends and allies. And so we stand with you, and with, of course, my wife, who sends her love, Camilla. And we thank you for including me. Thank you so much.